fibrous. Excuse me. C is cartilaginous, and the S is synovial. And of those three, the ones that we are most concerned with as personal trainers would be the synovial joints. So, just in case it wasn't immediately obvious, this is a representation of someone's skull viewed from the front left-hand side. Okay. So, fibrous joints, they connect bone to bone. They are a thin strip of collagenous, so in other words, made from collagenous tissue. This type of joint offers a little or no movement. So it's also known as immovable joint. So examples are in the cranium. So if you look along here, these lines, they're called sutures. Okay? And that's where we find these immovable joints. So for example, this bone here is the frontal bone. This one is the parietal, and this one is the temporal. So where the temporal, so these lines here, these sutures. So this is a joint, an immovable joint between the temporal bone and the parietal. And this suture here is the joint between the parietal bone and the frontal. Okay, so these are examples of immovable fibrous joints. Okay, so you see them in the cranium. They also exist in between the sacrum and the coccyx. Is the vertebrae are fused together, making them immovable. So this diagram here shows you the posterior or the back view of the sacrum, and this is the coccyx. Okay, so these are essentially five bones that have been fused together, and this is another four that have been fused together. So where they've been fused, these joint lines are immovable. Okay? So there's another example of immovable joints within sacrum and within the coccyx. This is the side view of the sacrum viewed from the right-hand side. So your bottom would be here and your legs would be hanging down here. And then this is the front view of the sacrum. Okay. This area. Okay. And it's your coccyx, your little tail. Um, Immovable joints. Okay. Your fibrous immovable joints. Okay. So that's your fibrous. Then we got the cartilaginous. So they connect bone with hyaline cartilage or fibrocartilage. Their purpose is to provide stability and some movement. So they're semi-movable. Okay? So the first ones were totally immovable, the fibrous. The cartilaginous allows a degree of movement. Okay? And they also provide shock absorption. So examples would be the intervertebral joints. So in other words, the discs that are in between your vertebrae. Remember that inter means between and vertebral, but let's always see the vertebrae. The intervertebral discs they act as shock absorbers. So, for example, here, this is a representation of one, two, three, four lumbar vertebrae. And these are your intervertebral discs. Okay. The outer surface is made from mostly cartilage. So, this is an example of a cartilaginous semi-movable joint. We've also got another example in the pubic symphysis. So this here is your pelvis. This bone here is the ilium. Then you have the ischium and the pubis. This is your okay. So this is a view from behind. So in other words, your glutes would be here, and obviously this is your femur, your thigh bone, and obviously there'd be one on the other side. So what I want to point out is this green bit, and this is your pubic symphysis. Okay, so that's a bit of cartilage, and it sits between the pubic bones. And here is another example of a cartilaginous semi-movable joint. Okay. So in the previous slide, you had the intervertebral discs, and then here's another example of the pubic symphysis. Okay, so cartilage, mostly cartilage that sits between the bone, that's going to form a semi-movable cartilaginous joint. And then we have the one that's, I say, we're most concerned about because that's where all movement occurs, and that's going to be your synovial. So they're called freely movable. They consist of a joint cavity or joint space filled with synovial fluid. The space makes them so it should be least stable, but most movable of the three types. Okay, so you have your fibrous, your cartilaginous, and synovial. The synovial joint, being that there's more space in there and because there's fluid around it, that's going to mean it's probably less stable, but it allows you greater movement than the other two joints. They are covered by a joint capsule. Okay, we're going to look at the structure shortly. So they're covered by a joint capsule and ligaments for stability. Their function is to allow for smooth movement with a wide range of movement available to them. And that degree of movement is going to vary depending on the type of joint. So some of your synovial joints will allow you a far greater range of movements and variety of movements compared with others. Just in case it wasn't clear, this is a representation of the ankle. Okay, so the lower leg. So this is going to be your tibia, fibula. So this is going to be the right outer, the left leg viewed from the outside. So this will be the little toes, the heel bone, and that's your fibula. Okay, and that's your ankle bone called the lateral malleolus. You don't need to know that for now, but that's the lateral malleolus, your outer ankle bone, and this is going to be the left leg. Okay. So examples of synovial joints are knees, hips, ankles. That you can go through them all. Shoulder, girdle, shoulder joint, hip, fingers, toes. All of those are examples of synovial joints. Now, within your workbook, you have to label a typical example of a synovial joint. So here's a representation of one. Now, anytime you look in A&P and they're showing you synovial joints, they always show you this kind of version where we have two long bones and all the other structures, but obviously not all synovial joints are made from long bones. So we have the periosteum, which is the outer lining of the bone. Okay, so this is a bone, and here is another bone, and this is going to be the joint. So the outer surface of the bone is covered by tissue, a layer of fascia called the periosteum. We have the ligament, which attaches one bone to another to provide stability. You have the joint cavity, okay, also called the joint part within the joint capsule. So the joint cavity is like a space within the joint. Okay. Within there, you have fluid called synovial fluid, which helps to lubricate the joints and reduce friction. You have the synovial membrane. So this green section here is the synovial membrane, and it is this membrane that secretes the synovial fluid that lubricates the joint. The ends of the bone are covered in this hyaline or glass-like cartilage. Again, that's going to protect against unwanted friction, wear and tear, and then osteoarthritis. And then we have this joint capsule or articular capsule that's around the outside of the synovial membrane. Okay, so you have the capsule on the inside, then outside of that you have the synovial membrane, and then around that is the joint capsule, and then around that is the other ligaments that's going to help stabilize the joint. So you need to be able to label these in your diagram, but again, as you know, it's an open book assessment, so there's nothing stopping you from looking at this while you label your diagram. The bone ends are covered with this hyaline cartilage, stabilized by ligaments. Okay, so this is common of all joints, irrespective of their shape, type. Enclosed with a fibrous capsule, so you've got your fibrous joint capsule here, and contains a synovial membrane, so that's the green area, and that secretes the lubricating fluid. Okay, so remember we talked about viscosity. The more viscous a liquid is, the thicker it is. So when you start warming up and moving your joints, you're going to make that synovial fluid less viscous, so that it becomes thinner. And when it's less viscous, it can start to lubricate and protect the joints a lot better. So that's one of the reasons for mobilizing your body as part of your warm up. Okay. So we have a tabular version that outlines the structure and function of your synovial joints with the three columns: the feature, the structure, and the function. Okay. So the hyaline cartilage is smooth and tough, made of collagen, and its function is to reduce friction between one bone and another. We have the joint capsule, which has two layers. The outer layer is made of collagen, excuse me, that attaches bone to bone, and it works alongside the ligament. And then you have the inner layer, which is the part that is going to form your synovial membrane. Okay? So outer layer limits and controls the movement along with the ligaments. Nerve endings provide proprioception or proprioceptive information. What that means is when we're talking about proprioceptive information, that's to do with the position of the joints. So proprioception It's about joint positioning. Well, it's not purely, but one of the functions of the proprioceptors, certainly within joints, is to send a signal back to your brain about joint positioning. Okay, so a simple example is, let's say you stood on a stone and your ankle went over. If you have poor proprioception, you probably won't be able to correct yourself before spraining an ankle. Okay, if you've got good proprioception, then you might be able to correct yourself quickly because you've had a signal from the joint back to your brain telling you about the joint position and the fact that the ligament's been stressed. So it will then send them a signal back to your muscles to help correct you. Okay, so that's what we're talking about proprioception. Okay? And then, as we said, it's got two layers. So the inner layer forms the synovial membrane. You have synovial fluids. That's a viscous lubricant made mainly of water. It's got nutrients like hyaluronic acid, lubricates the joint and it helps with shock absorption. Then we have the ligaments, so they're on the outside, made primarily of bundles of collagen and various proteins, and they will stabilize the joint, preventing unwanted motion. Okay, because with any joint, you don't want that joint to be able to move completely out of its range because it will become damaged. So consequently, one of the roles of the ligaments is to stabilize the joint. Another one is to prevent unwanted movement. Consequently, when you have sprained a joint, like an ankle joint, then what you've done, you've torn the ligament because it's been forced beyond its natural range of motion. That's what causes it to tear. And then we have the synovial membrane, which is within the joint capsule, or cavity rather, secretes synovial fluid and nutrients and also removes waste products. That's the structure. In terms of functions, so secretes synovial fluid, removes waste products, and helps to lubricate the joint. Okay. So these are the tables that we've just looked at. I've left the descriptors there. So let's see if we can name the feature based on these descriptions. So smooth and tough, made of collagen, and it resides on the end of bones. That's going to be the articular or hyaline cartilage. Dense outer layer is made of collagen that attaches to bones and helps limits movement. And there's the inner layer, which is the synovial membrane. So that's going to be the two-layered joint capsule. Okay. So what was the name of that viscous lubricant made mainly of water, the fluid within the knees? That's going to be your synovial fluid. We have something that's made mostly of collagen and got some protein, and it helps to stabilize the joint. So what was that? Takers. That's going to be your ligament. And then finally, what particular structure is responsible for secreting the synovial fluid? And that's going to be the synovial membrane. Okay. So you need to be able to put this information across when you're doing the LO2 workbook later on today or this week. Let's look at the picture first, a representation of the right ankle viewed from inside. Okay, so this is the right ankle. Okay. So obviously heel bone, that's going to be your big toe, and it's going to be the tibia and fibula. So the next few slides just give you examples of synovial joints. So the ankle joint, synovial hinge joint. So it's a hinge joint between the talus. Okay, so the talus is this bone here, and the tibia and fibula. So remember, tibia and fibula, they're your lower leg bones. And where they articulate with the talus, that's going to be a hinge joint. Okay? So the joint allows plantar flexion, that's where you're going to point the foot down, and dorsiflexion, where you're going to move the foot back up. You also have inversion, where you turn the soles of the feet inwards, and eversion, where you turn the soles of the feet outwards. But that's not between the tibula, between the tib and the talus. That occurs between the talus and the calcaneus, which is the heel bone. Now, we tend to use these terms, excuse me, pronation and supination as well, but be aware that the correct definition of ankle pronation is a combination of dorsiflexion, eversion, and abduction of the foot. Okay, so the true definition of pronation is a combination of three movements, and same with supination. So ankle supination involves plantar flexion, inversion, and adduction. However, in many manuals, and I'm quite sure with the manuals that we use, we tend to use the word pronation as the same as eversion, and we tend to use the word supination as the same as inversion. Okay, but any of you who go on to do, say, sports therapy and sports massage, you'll come to learn that in fact pronation and supination in the ankle are a combination of three movements. Okay, but not something that you need to know for the course right now. Okay, it's just something that I added here in red. Another example of a synovial joint is a knee joint. So it's a synovial hinge joint made from the femur, tibia, and patella. So this is an X-ray of a leg. So this is the femur, the thigh bone, patella, your kneecap, tibia, and the fibula. Bone ends are covered in hyaline cartilage. There are also two pads of fibrocartilage or meniscus. So on top of the tibia here, you have two C-shaped cartilage discs called the meniscus or meniscus, plural, menisci, singular. That I think I've got that right around. Menisci, meniscus. Well, either way, meniscus. Yeah, let's call it singular for meniscus, menisci, plural. Could be the other way around. Okay. They aid with shock absorption. And the joint allows for flexion and extension. So flexion is when you bend the knee, extension is when you straighten the knee. Okay. However, I've added some notes here. So note, when the knee is flexed, or in other words, when the knee is bent, there is also medial and lateral rotation in the knee. Okay. The knee can rotate laterally and medially, but only when it is bent, when it's flexed. Again, you won't need to know this in terms of completed the course. You just need to know about flexion and extension. Hip joints. So it's a synovial ball and socket joint. So this picture here, excuse me, shows you the femur, which is the thigh bone here, and the head of the femur forms the ball. And then the socket here, okay, called the acetabulum, is created by the ilium, the ischium, and the pubis. Okay, so they come together to form the socket. Okay, right. Let me just see who needs to be muted. So you have now. So some of this. Quite possibly, but this is for LO2, and this actually is the correct PowerPoint for LO2. Because I think LO1 might have been about bones, but this is specifically about joints. Yeah, yeah, yeah. Okay, cool. Yes. So just let's go in. Yeah. So the joint is made deeper and stabilized by a cartilage ring. Okay. Um, called the labrum. So see this here? This is a ring of cartilage, and that's the labrum, and that makes the socket deeper and more stable. The joint allows flexion, extension, abduction, adduction, internal and external rotation, and circumduction. Okay, so we've got listed here 1, 2, 3, 4, 5, 6, 7, 8 movements. 4, 5, 6, 7, 8. What has been, sorry, there are 7 movements because we've got internal and external. So what's been missed is also horizontal flexion and horizontal extension. Okay, so there's actually 9 movements rather than these 7. Example of horizontal flexion, also known as horizontal adduction, is the inner thigh machine. So those who don't know, you sit down, you've got the pads on the inner thigh, and you bring the thighs together. Okay, so that's horizontal adduction, but also we have horizontal abduction. So you're sitting on the same machine, the pads on the outside of your knees, and you're going to bring your legs apart. That's horizontal abduction. So there are in fact 9 movements available at both ball and socket joints. So for the shoulder and the hip, they all have exactly the same 9. Flexion, extension, abduction, adduction, internal rotation, external rotation, circumduction, horizontal flexion or adduction, and horizontal extension or abduction. Okay, so that's all 9 movements, shoulder joint and hip joint. Okay, yeah, I didn't realize I added that as well. So I've added that on. Anything in red that you see when you get this is stuff that I have added. Oh, yeah, a couple of others that I added. We have diagonal flexion and diagonal extension. Now, these are terms you will not have heard of, I think. These are terms that will not be in your manual, and you do not need to worry about them for your manual. However, as good potential personal trainers, I think it's important that you know more than what's in the manual. Okay, so let me show you what horizontal flexion looks like. I'm just going to make sure that I can see me, and if I can see me, you can see me. All right, so diagonal flexion is from, let's say, from your pocket on the opposite side going up. That's diagonal flexion. Okay, so diagonal flexion is from opposite pocket, yeah, or from this pocket diagonally across. That's horizontal, so diagonal flexion. Diagonal extension is the opposite. So from here, pulling down, or from here, pulling diagonally across. Okay, so going down diagonally. Those are two examples of horizontal extension, and then diagonally upwards. These are two examples, or the examples of diagonal flexion. Okay, but like I said, for the course, you don't need to know that. That's that. Let's continue here. Right. So before we look at the text, this is a representation of your pelvis. So again, remember your ilium, sacrum, pubis, ischium. So let's look specifically at a particular joint called the SI joint, sacroiliac joint. So pelvis consists of two sacroiliac joints. So you can see them labeled here. Okay, sacroiliac joints. And they are gliding joints between the ilium, the big wing-shaped bone here, and the sacrum. The SI joints, they are weight-bearing joints, so they transfer a lot of weight from the upper body through to the legs. Okay, so very, very important, strong joints here. Okay, very, very important joints. However, the movements at these joints are very small. Okay, which should be expected because if they are major weight-bearing joints and they transfer all the weight from the upper body through to the legs, imagine if these were very easily to move, they would probably be damaged quite easily as well. So there's only a small amount of movement in there, and they bear a lot of loads. So it's called your SI or sacroiliac joint. Sacrum, ilium, sacroiliac joint. Okay, so here's your sacrum. This is your ilium, and it's the joints formed here. Okay. Pubis symphysis is a cartilaginous joint, so we looked at it earlier, in which joins the two pubic bones, so pubic bone here, pubic bone there. The pubic symphysis allows a limited movement while maintaining stability of the pelvis. And then during pregnancy, we have a hormone called relaxin. Now, what relaxin does, it softens cartilages to allow for an easier passage of the baby as it's being born. And one of the ligaments that gets stretched to some degree is that pubic symphysis. Okay, because remember, you've got a baby sitting around here. It's got to pass through a relatively small opening, and for that to happen, you need to have the ligaments nice and loose so that the bones can separate to some degree to facilitate passage of the child. This example here, this is the elbow. So this is your humerus and ulnar and radius. So the elbow joint is a synovial hinge joint made up of the humerus and the ulna. The bone ends are covered in hyaline cartilage, and we have flexion, which is elbow, bending the elbow, and extension, which is straightening it. Okay. We also have pronation, which is turning the palms down, and supination, and they occur, it says, at the superior radio-ulnar joints. This here. Okay. This is the ulnar radius. So it's the joint between the radius and the ulna, called the radio-ulnar joint. This is where we actually get pronation and supination. It doesn't occur here. It's just flexion and extension here between the humerus and the ulna, but have pronation and supination between the radius and the ulna. Okay. This one here is the wrist. So this is the ulna, radius, carpals, of which there are 8, and then your 5 metacarpals. Okay, so ulna, radius, 8 carpals, and your 5 metacarpals. Remember, meta means beyond. So metacarpals, they are the bones that are beyond the carpals. Okay? So we have an example of an ellipsoid joint made up between the radius and the carpal bones. Okay? It's not this one here, it's on this side, okay, because that's the ulna, the radius. So between the radius and the carpal bones is your ellipsoid or condyloid joint. So the joint allows the same movement as a ball and socket joint, but with less range of motion. Okay, so you get pretty much the same movements available as a ball and socket joint, but to a lesser degree. So this table, do not try to commit to memory, okay, because in all my years in this industry, which are many, many, many years, and working as a sports therapist as well, I don't even know these, and there's no need. Okay? I think it's important to be aware of them and have access to these figures, but no need to try to remember them. So what these figures, what this table is showing you here is the typical range of motion in degrees of the various joints. So for example, let me just make sure that, again, if I can see me, you can see me. And let me come slightly further back. Yeah, 35 back. So we have flexion of the shoulder. So we're saying we have around about 160 degrees. This is neutral, and then that's 90 degrees, and then all the way back will be 180. But some people haven't got that. Okay, it says extension from neutral without leaning forward. That's about 50 degrees. But remember, these are averages. Okay, internal rotation I disagree with because this is neutral, and it says internal degree is only 45. Okay, this is the anatomical position. So I think 45, you've probably got more than 45 degrees. External rotation is 90 degrees. Okay? But it also depends on the position you're measuring from. So if you're measuring from here, you might get less movement than if you're doing it from here. Here, I can get up to 90 degrees. Okay, again, let me just make sure that you guys can see me. Yeah, so from here, I've got less external rotation than I have here. Okay, so always consider the shoulder or the joint position when we're looking at the available range of motions. Okay, but like I said, just be aware or make sure you've got access to something like this, but do not try to commit to memory unless, of course, you have nothing better to do with your time. All right. We covered planes of motion in level 2. So can we remember these planes of motion? Okay, remember this one, we have the bodies divided into front and back portions. Here, the body is divided to left and right, and the body is divided top and bottom. So can we remember these planes? So we have frontal, sagittal, and transverse. Now, one that this bit I've added, it's important for you to know, but not from a course perspective. So there'll be nothing in the course that requires you to talk about this one, but it is important that you are aware of it, okay? Because you probably do this movement at some point in the gym anyway. So frontal, sagittal, and transverse, the ones from the previous page, they're known as the cardinal planes. Okay? So they're cardinal planes, but we also have the diagonal or oblique planes. Okay? And they also coincide with what I showed you earlier when I talked about oblique or diagonal flexion and diagonal extension. Okay, that's where they coincide with. So what you see here is a representation of a lady doing diagonal flexion. Okay, so this is diagonal flexion. When she brings the arms back down, that's diagonal extension. Okay, the exercise is reversible chop, and you can see here these examples of these diagonal planes. Okay. But like I said, don't need to be aware of that from a core perspective, but from a personal development perspective, important to still know. So alongside our planes of motion, again, remember from level 2, we had axes. So that's where if you have a rod going through the front of the body, through the side of the body, and through the top of the body, okay, these are going to be your axes. Okay, remember the names of those axes? And if you do, just don't vocalize it, just answer in your own head. So this one was the anterior posterior. Okay, and that's the same as the frontal plane. So with the rod going through the body, if I was to turn the rod, I'd be moving in this way. So that's your frontal plane. This next one is your mediolateral. So with the rod going through the side of the body, if I was to turn the rod, I'd be doing this. So that's going to be flexion and extension, which is your sagittal plane. And then the next one, rod going through the top of the body, right the way through the bottom, that's going to be your longitudinal. So if that rod was turned, I would move in this plane, and that's going to be your transverse. Okay. So the next few slides, we're looking at examples of movements using those planes. So sagittal, frontal, and transverse. So with the sagittal, we have flexion and extension. Okay, flexion, extension, plantar flexion, and dorsiflexion of the ankle. Frontal plane, okay, we have abduction. So anything in this plane, abduction, adduction, side flexion or lateral flexion, and reduction. Remember, reduction is returning from side flexion to neutral. So anything here or moving sideways is going to be your frontal plane. And then we have transverse. Okay, so rotation, it's a spinal rotation, but also horizontal flexion and extension. Okay? So horizontal flexion extension, okay, that's all transverse. So transverse is here, transverse is there, but also pronation, supination. It's transverse. Okay. So again, just quick revisions. So sagittal, what did we have? Sagittal, we had in the elbow, flexion extension, in the knees, flexion extension, and the hip, shoulder, but also we had dorsiflexion and plantarflexion. Frontal plane, remember this way. So we had abduction, adduction, we had lateral flexion and reduction. And then remember with the transverse, we had rotation, we had a horizontal flexion extension, and we had pronation and supination. Okay. So those are movements, but now let's look at examples of exercises. Okay. So lateral pull down, remember that's this one here, you take the bar and you're pulling down. That's a frontal plane. Okay. Remember anything here, it's frontal plane, because we have shoulder adduction. As you're pulling down, you're adducting the shoulders and you're flexing the elbows. Now, even though we said flexion and extension were sagittal, that's if it's done in the conventional way. And this is not the conventional way for doing an elbow flexion exercise. Okay, conventional way would be here, but the elbows are still flexing. But because of the position in relation to the body, this is now not going to be elbow flexion in the sagittal plane. It's elbow flexion in the frontal plane. Okay, because remember everything here is frontal, even though the elbows are still flexing and extending. This will be lateral pull down. It's going to be a frontal plane exercise. Now, biceps curl done the standard way, which is going to be this way, standard way, that is going to be sagittal. Okay? So elbows are flexing from their typical position. Yeah. Barbell back squat, okay, for the most part, that's going to be sagittal as well. Okay, so when you do your knees and hips and ankles are going to be flexing and extending, and you're going to be going to dorsiflexion. Okay, but like I said, that's going to be if you're doing it the standard way. It's going to vary slightly if you're doing something like a sumo squat, where the feet are wide and knees are pointing out, because now you've got a little bit of transverse in there. But if you're just in a basic squat where your feet are something like hip width and knees and toes are pointing pretty much forwards, then yeah, when you dorsiflex the ankle, when you flex the knees and the hips, that's all going to be sagittal plane. Okay. Push-ups or press-ups. So with a wide position, okay, with a wide position, that's going to be transverse. Okay, because your shoulders are going to horizontal flexion, also known as horizontal adduction. Okay. And the elbows are extended, but not in their typical position. So in other words, not in a sagittal type position. So the elbows are flexing in this wider position. Okay, so consequently, the whole movement is going to be transverse plane. If you did what we call triceps push-ups, which is where the hands, so the arms are tucked into the body, then that will all be sagittal. So the plane of movement is going to be determined by the hand position when it comes to doing things like push-ups. Okay. Remember, any questions, do ask. Right. So lateral pull down, what did we say that was? Okay, so we said lateral pull down, we said that's going to be frontal. A typical bicep curl, going to be sagittal. Typical barbell back squat is going to be sagittal. And certainly a wide hand position for the push-ups is going to be transverse. We definitely covered this at level 2. So this is about anatomical positions. Let's see how much of this you can remember. So we're looking for the missing word. You have the descriptors down here on the right hand side. Okay, so all the descriptors are here, and the positioning of the missing word. So what's the missing word for front of the body? Anterior. What's the missing word for back of the body? Posterior. Okay. So we have an anterior view, we have an anterior view or front view, and we have a posterior view, back view. A position higher than another. Here, and then a position lower than another. Here. Position in the limb that is nearest to the trunk. Approximate. Position in the limb that is furthest from the trunk. Distant. Position towards the midline. Heel. Position away from the midline. Lateral. And then furthest from the surface. Deep and closest to the surface. Superficial. So again, these are terms that will be quite useful for you to know. You may not see how when it comes to personal training, but certainly when you're communicating with other personal trainers, for example, or you're making referrals or you receive referrals, if you don't know what is being spoken about, then you're going to be in a very, very difficult position. Shoulder joints, so that's another example of a synovial joint. It's a ball and socket joint. The ball is the head of the humerus, and the socket is the glenoid cavity of the capsule. So what we have is a representation here of the shoulder viewed from the front. Okay, with obviously muscles taken off. This is your clavicle. Okay, long hair. This will be perhaps your supraspinatus. This is the scapula, and then the head of the humerus. So that's going to be the ball, and this bit's the socket. Stabilizing factors. So we have what's called static stabilizers, just like in the hip. Okay, so we have the labrum around here. Okay, that's going to help make the socket a little bit deeper, a bit more stable, but it's not going to be as deep and as stable as the hip joint. Because when you think about it, the hip bears a lot of load as well, doesn't it? It's all the way from above the body through the sacrum and then through the hips. So even though the hip has a wide range of motion, it has to have a lot more stability. So consequently, the ball fits more into that socket. Okay. Now the shoulder doesn't have to bear quite so much load, so the socket is shallower. It's a lot shallower. So your hip one is going to be more round. The shoulder one is going to be a little bit more shallow. However, it is still you still have that kind of labrum, the cartilage around there, just to increase the stability within the joints as well. Okay. So what type of joint did you say it was? The B and S. Okay, so ball and socket. The ball is the head of what bone? Okay, so your arm bone is the socket is much shallower than the hip socket, making it relatively, if it's less stable, it's going to be stable. Stabilizing factors. So what's around the rim of the socket acts to make the socket deeper? Okay. That was the labrum. And then we have bits of cartilage that attach, go across the joint to stabilize it. They're called ligaments. And then the joint capsule surrounds the entire joint, adding to its stability alongside with the ligaments. Let's look now specifically at the shoulder joints. Another part of the shoulder joint. So we have dynamic stabilizers or the rotator cuff. So what you looked at before were passive, so ligaments, joint capsule, okay, that kind of stuff. Now we're looking at dynamic. And when it comes to dynamic stabilizers, we're always referring to muscles. Okay? So there's a term you may be familiar with called the rotator cuff. This consists of 4 muscles that stabilize the shoulder joint and assist with movement. Scapular movements. Okay, so scapula, that's your shoulder blade. As the arm moves, the scapula moves with the humerus to maintain as much contact between the scapula and the humerus as possible. That's called the scapulohumeral rhythm. So when you abduct, it is not just the humerus that is moving, the scapula rotates as well. Okay. And they work in a ratio of 2 to 1. So for every 1 degree of scapular rotation, you have 2 degrees of shoulder movement. So all of this 180 degrees, okay, um, 1/3 of that is the result of the scapula, and 2/3 of that comes from the shoulder joint. Okay? So you will have 60 degrees of rotation in the scapula, and 120 degrees comes from the shoulder joint, and that's going to give you your full 180 degree. Okay. Um, The muscles of the scapula include the trapezius, rhomboids, levator scapulae, serratus anterior, pec minor. So what I have added now is a question here: how many muscles do you think attach to each of your shoulder blades or your scapula? Let's have a quick guess. How many do you reckon is attached to each one? So you may well be surprised to find each of your shoulder blades has 17 muscles attached to each one. 17 muscles. So again, I've added this slide just to show you where those 17 are attached. So all the blue bits, they are the surface area of attachment. Okay. So in other words, if you look at this one here, the subscapularis takes up this entire surface. Over here, the infraspinatus takes up this entire surface. Okay. So this is 2 pictures of your shoulder blade. Okay. This is the right shoulder blade viewed from the front. So the ribs will be sitting here. And this is the right shoulder blade viewed from behind. And all of these blues are the areas of attachment of the 17 different muscles. So I think it's fair to say, well, no, I know it's true to say that the scapula is the one bone that has the most number of muscles attached to it. This one here shows you the rotator cuff. So again, this is the back of the right shoulder. This is the front of the right shoulder, showing you the rotator cuff muscles. So you have the supraspinatus, supra meaning above, and it's the spine of the scapula. So this is the spine of the scapula here. The supraspinatus is above the spine of the scapula. Infra is below. So this one is below the spine of the scapula, the infraspinatus. You have the teres minor. So teres means round, teres minor. And then you have the subscapular. So sub means below or beneath. So beneath the scapula, if you like. It's showing you the teres major as well, but the teres major is not a rotator cuff muscle. So there's only 4: the supraspinatus, infraspinatus, teres minor, subscapularis. Those are your 4 rotator cuff muscles. They will stabilize the joint, and they will also control and initiate movements like abduction and internal external rotation. Okay, so can you remember the names? This one is above the spine of the scapula, so that's the supraspinatus. This one here is below the spine of the scapula, so it's the infraspinatus. This one here sits above, well, close to the teres major. So it's the teres. I got it wrong. Sorry, I missed out. I was pointing at this one. Subscapularis is on the anterior side of the scapula, and then the teres major and teres minor. Remember, major is not a rotator cuff muscle, but the teres minor is. Okay. Can't remember if that comes up in the workbook, but if it is, well, you have the presentation to remind you. Short and long-term effects of exercise on joints. So in the short term, in other words, during exercise, synovial fluid will be released to lubricate the joints. So as soon as you're exercising and warming up, that synovial membrane is going to secrete this fluid. That fluid is going to become less viscous. In other words, it's become thinner. It can lubricate the joint a lot better. Another short-term effect of exercise is improved circulation during exercise, which brings oxygen and nutrients to the joint. An effective warm-up will improve your range of motion in the short term. Okay, so when you're warming up, as long as you're doing it effectively, you'll start to increase that range of motion, preparing you for the workout. That's your short-term effects of exercise on the joints. Now let's look at the long-term effects. You have increased stability due to stronger ligaments and tendons, improved cartilage health. Okay, so if you're doing um, some degree of impact activity, okay, not excessive amount, but say moderate amounts of running, for example, or skipping, for example, that's going to improve the health of the cartilage, the hyaline cartilage that covers the ends of the bones. Consistent exercise will have a more permanent effect on improved range of mobility and flexibility, or sorry, range of motion and flexibility. And then, so something out of the way. And then a balanced exercise program will lead to better joint alignment and posture. But it's important that it's a balanced exercise. Okay? Some of you may have gone to the gym and seen guys who do a lot of lifting weights and they're very protracted. Okay? That's because they do way more pushing. Now there's working their chest more than their upper back. So that's why they may look a bit rounded. Similarly with people who box, or the boxers, because there's lots of forceful movements going forward, that pulls them into protraction. So a lot of boxers have that protracted position. Okay, again, that's because there's an imbalance between their activity and their exercise. So there's a lot of time spent forcefully pushing the arm forwards, but then they're not in the gym forcefully pulling backwards. So then you're going to get this imbalance in the joint and then potential injuries. As a personal trainer, it's going to be important that you are aware of any imbalances that your client has, and then put in place some programs that's going to address that balance, that imbalance. Okay. One thing that I'll tell you from experience, one thing that a client that will really impress your client is if you make them aware of something that's in their interest to address. They'll come to you with a specific goal. Once you've done things like a postural assessment, for example, you're going to see things that they weren't aware of. Okay, so now you can add this to the goals, the things they need to achieve. Okay? I mean, I've had clients who didn't realize that they were slightly elevated on one side, slightly rotated, because when you're looking in the mirror, you're not looking for that. You're looking at putting on your lippy or doing your hair or whatever. Okay, but then when someone says, "Okay, I'll take the posture photo of you," and you can show them, you can show them how they are in balance, that impresses them. Okay, and you say, "Right, now we're going to work on stretching this, strength that, whatever it is you need to do." Okay, so always good to do things like posture analysis and look for muscle imbalances. Okay, so so even though it says "can you now," I mean that would be unrealistic to be able to say yes to all of these. So what we covered is describe the structure and function of fibrous, cartilaginous, and synovial joints. Okay, remember fibrous joints immovable. Example in the cranium and the sacrum and the coccyx. Um, Cartilaginous, so provides some degree of movement. Pubic symphysis and intervertebral discs, example, and the synovial joints to allow a wide range of motion. Okay, and remember the different joint types. Okay, so that bit would have been in the bones one that you did. Okay, so maybe you had well, also in this as well, ball and socket, gliding, plane, paddle, contomoid, all that kind of stuff. Describe the structure and function of the components. So remember we talked about the joint capsule, which protects the joint, synovial membrane, which secretes synovial fluid, the fluid itself that lubricates the joint, the hyaline cartilage that protects the ends of the bones, and then the ligament that's going to provide stability towards the joint. Describe the type of joint and the movements available. So we talked about hinge joints, so typically flexion extension. We talked about let's no, do it the wrong way around. So if you have shoulder joint, let's do it that way. Shoulder joint is going to give you things like 9 different range of motion, so abduction, adduction, extension, flexion, blah blah blah, all that stuff. We said things like elbow is going to give you flexion extension. We have pronation, supination between the radius and the ulnar. Knee is going to give you flexion extension, but remember when the knee's flexed, we have rotations. The hip has the same 9 movements as the shoulder joint. Ankle, we have dorsiflexion and plantarflexion between the tibia and the talus. But then between the talus and the calcaneus, we have inversion and eversion. Remember the toes, wasn't mentioned, but we have flexion, extension, and believe it, you do have abduction, adduction, and in theory, you have circumduction of the big toe. Fingers, you have flexion, extension, abduction, adduction, circumduction, and then opposition. Opposition is between the fingers and thumb. Okay, circumduction in the wrist. So so all of these will be in your manual. Okay, so it is very important that you know what movements are available. The planes of motion. So remember, we had frontal, which is abduction, adduction, side flexion. Okay, we had sagittal, which is flexion, extension, dorsiflexion, plantar flexion.